This tiny glass slide can contain billions of pixels. So can AI become an extra pair of eyes for the tissue slides too? But first, who actually reads these slides? When we think of cancer scans, we usually picture an X-ray, CT scan, or a mammogram. But some of the most important answers come from something much smaller, a thin slice of tissue placed on a glass slide. Once that slide is digitized using a slide scanner, it becomes a huge image packed with detail. And before a pathologist has searched every part of it, AI can scan the slide and flag regions that may need attention. So can AI become an extra pair of eyes for the tissue slides too? But first, who actually reads these slides? Pathologists or doctors who diagnose disease by examining cells and tissues. They do not simply hunt for bad-looking cells. They look at the bigger picture, how tissue is organized, how cells are shaped, how they are staining, and how a possible tumor interacts with the tissue around it. That combination of pattern recognition, biological knowledge, and clinical context is why pathology is far more than just looking down a microscope. And that is exactly why reviewing a slide is harder than it looks. A digital pathology slide is not like a normal photograph. Think of it more like Google Maps for a city made of cells. Zoomed out, you see the layout of the tissue. Zoomed in, you can inspect individual cells, dividing cells, immune cells, or tiny areas where cancer may be starting to invade. The challenge is that pathologists may need to move between these different scales repeatedly while making decisions that can affect diagnosis and treatment. Scanning the slide is not the hardest part. But before AI can help, the hospital first has to make digital pathology work safely. Turning a glass slide into an image is only step one. The hard part is building a hospital-wide system around it. Reliable slide scanners, enormous secure storage, fast networks, staff training, and new ways of tracking and reviewing cases. Every image has to be high quality, linked to the correct patient record, and available when the pathologist needs it. And before digital slides are used routinely for diagnosis, the laboratory must prove that reviewing them on screen works reliably for the intended clinical use compared with the traditional glass slide workflow. So digital pathology is not just a scanner project, it is a whole hospital transformation. Digital pathology guidance highlights infrastructure, training, storage, and interoperability as central requirements. Once that system is in place, AI can begin to help. AI does not diagnose cancer by itself. Once the digital foundation is in place, AI can be added as another carefully tested tool. One useful way to think about pathology AI is as a smart highlighter. It scans a whole slide image and ranks areas by how suspicious they appear. In effect, it can say, this region looks low risk, or this region deserves a closer look. That could help a pathologist find relevant areas faster, but the pathologist still decides what the pattern means and whether it represents cancer, inflammation, a technical artifact, or something else. And highlighting is only the beginning here. AI can do more than spotting suspicious tissue. AI in pathology is not only about finding cancer. It can also help measure things that are hard, repetitive, or time-consuming to assess it manually. It may help detect possible cancer regions, count cells caught in the act of dividing, flag tiny metastases in lymph nodes, measure biomarker staining, and map immune cells in and around a tumor. These measurements can contribute to diagnosis, cancer grading, prognosis, and treatment planning, but only when the specific tool has been properly validated for its intended use. A classic example comes from checking lymph nodes in breast cancer. A lymph node can be mostly normal tissue, with only a tiny hidden cluster of cancer cells inside it, like trying to find one small stain on a huge map. In a research challenge, some AI systems were very good at spotting these tiny areas. Under time pressure, the best AI system performed better than the pathologist in that specific test. But that does not mean AI has replaced pathologists. When an expert pathologist was given more time to examine the slides, their performance was very similar to the best AI systems. And this was a research challenge, not proof that AI works the same way in every hospital. AI can scan the entire slide quickly and point to places that might be important, but the pathologist still uses their training and judgment to decide what those areas actually mean. But cancer is not only about where tumor cells are. A tumor is not just cancer cells, it is an ecosystem. AI can also help analyze biomarkers and the tumor immune environment. Instead of only asking, is this marker present, digital analysis can help quantify how much staining is present and where it appears. Is it mainly in tumor cells, at the tumor edge, or in nearby immune cell rich areas? That matters because cancer is not simply a clump of abnormal cells. It is an ecosystem where tumor cells, immune cells, blood vessels, and surrounding tissue can all influence what the disease does next. And now researchers are asking an even bigger question. Could a pink and purple tissue slide reveal hidden biology? Researchers are training AI on routine hematoxylin and eosin stained slides, the pink and purple stained images used every day in pathology to look for patterns linked with mutations, prognosis, and possible treatment response. The idea is not that an image replaces genetic testing. Instead, the image may contain subtle patterns associated with underlying biology, patterns that are difficult for humans to recognize consistently at scale. This is promising research, especially in immuno-oncology, but many of these prediction tools are not ready for routine patient care decisions yet. But before any AI tool can be trusted, it must pass the real-world test. A perfect AI score in one hospital can fail in another. An AI model can perform brilliantly on slides from one hospital, then lose accuracy when it sees slides from another. That is because hospitals can use different scanners, staining methods, tissue processing systems, and patient populations. So a model cannot be judged only by a polished benchmark score. It must also be tested across different hospitals and real clinical workflows. A large systematic review found high average diagnostic performance across digital pathology AI studies, while also identifying frequent risk of bias and concerns about whether results would apply broadly in real care. That is why AI must support pathologists, not replace them. The future is not AI versus pathologists. The best way to understand pathology AI is as a partnership. AI can scan large slides, flag suspicious areas, count features, and produce quantitative maps. But the pathologist brings context, the patient's history, unusual disease patterns, slide quality, additional tests, and the judgment needed to turn an image into a responsible diagnosis. So no, AI is not replacing pathologists. It is becoming a potentially powerful assistant, an extra pair of eyes, a rapid counter, and a tool for finding patterns that may otherwise be missed.